Thank you, John, and thanks to the National Coalition and the Schaeffer Center. I'll note that the last time I was in this hall was about 20 years ago at my father's retirement party. My father was at the USC Medical Center, chair of the Department of Family Medicine, so it's great to be back. When you hear us talk about affordability, you really get a sense that it's the elephant, and we're looking at it from different sides of the picture. And I'm going to talk about the individual market as one piece of affordability, but also use that as a way to talk about the rest of the delivery system. Because if you talk to the average American, healthcare affordability is one of the top 3 issues they care about. These are people with employer-based healthcare or Medicare, et cetera. The affordability issues that we're talking about are not just for the uninsured, aren't for the, it is an American-wide issue. So we'll see if I've learned how to proceed with this. So I will rocket through slides, but I want to take you on a brief journey to a year ago where nationally the individual markets were stabilizing. Now, we in California have sort of had this idea that things have been pretty stable, and they have been in California, but the rest of the nation was sort of catching up to California. And we've seen, even in the last few months, profit reports on health plans that actually did okay in 17. But then we had a new president and a lot of concern about the year we just entered into. There was huge uncertainty going into 2018. Was the penalty going to be enforced? For those of you that don't know, it's still the law. It goes away in 19. Was there going to be marketing spending? For those of you in California, you might have seen Covered California's ads. If you haven't, I don't know where you live. But in the rest of the nation, 35 states rely on the federal government to do marketing. The federal government cut its marketing spending from $100 million to $10 million. Let me note that $10 million in marketing spending for 35 states to promote enrollment. We spent over $105 million in California. Huge uncertainty for health plans saying who are we going to get in. The third thing that happened was the Trump administration said we will no longer directly fund something called cost-sharing reduction subsidies. When we talk about affordability, it's premiums and what you pay at point of care. Cost-sharing reduction subsidies addresses point of care, spending $5 for an office visit instead of $40. Health plans had to pay for it, and we developed a workaround that was then used by much of the nation, about 45 states that did a workaround that protected unsubsidized people, et cetera. What did that mean in 2018? And we've just wrapped up open enrollment. First, the good news was there were no bare counties. And it was a huge struggle in much of the nation to have one plan left, which is what 30% of Americans have, one plan in the individual market. In California, it's about 5%. Number 2, that CSR workaround meant that the tax credit went up for the 85% of the people in individual markets that get subsidies, the individual marketplaces that get subsidies, which meant healthcare was more affordable for them. And people that are unsubsidized, mostly that buy off-exchange coverage, were not footing the bill. That was a huge deal. So if you were getting a renewal for coverage, your bill went down, okay? Third, absolutely. So third, though, there wasn't marketing outside of California, except for the 12 or so, 13 state-based marketplaces, but there was a boatload of news coverage. And it wasn't just about repeal and replace, it was about enrollment periods. And we actually did a study on that. It was a huge spike. So what happened? Well, first, on the left-hand side, the top gray line is on-exchange individual enrollment. Federal marketplace and state-based marketplace. It dropped about 5% to about 12 million people. That's much less of a drop than many of us thought there might be, but you know, it's still a drop. California is on the right-hand side. On exchange, we've been at 1.4 million for the last 4 years. The dark little line is 420,000 people that newly enrolled. And the reason I want to flag this is there's sort of a harbinger of bad news coming down the track. The dark blue line you see trending down is new enrollment in the federal marketplace states. Okay? Since 2016, new enrollment has dropped 40%. New enrollment are healthy people. If you don't have new people coming in, just keeping people in a risk pool means things go south. They go up in terms of the price. because it's less healthy people. The other thing all of these numbers show is what are called marketplaces, where people can get subsidies. About 40% of the individual market is off marketplace. People that buy direct from Kaiser in California, or Blue Shield, or Health Net, or in other states, they don't go to the federal marketplace, they go direct to a health plan. The data that we have is that off-exchange, unsubsidized enrollment nationally has dropped about 30% in the last 2 years. That's a bad thing because it's healthy people dropping out of coverage. So when we talk about affordability, affordability in the individual market is about risk mix. It's about getting people in. So what do we do in California? Just a brief tour. We spend a boatload of money on marketing. Marketing matters a lot. For many of you, this is a storefront. We have 800 storefronts in California. You walk in there, you see people wearing the polo shirts, they cover California. They are not our employees. They work for individual insurance agents, community groups. About 45% of our enrollment comes through agents. For those of you in California, you probably have seen or heard about us. The average Californian saw or heard about us in each open enrollment period about 50 times. Okay? That's what it takes to sell insurance. Because buying insurance isn't, I talked to the economists about this. Do you want to spend money today for something you never will be able to use, you hope? That's not a good sell. And even with employer-based coverage, where you're enrolled when you get your job, there's only a 79% take-up rate. So we've done a pretty good job. Let me take you to affordability. This is one of these good news, bad news stories. Top line, gray, is for the unsubsidized Californian, what's it cost them to buy coverage? It's about $500 a month. Premiums have gone up about 7% a year over the last 4 years. Now I say, damn, we've done a great job. 7%, hallelujah. And because California has a 20% healthier risk mix, if we hadn't done our marketing, those premiums would be like $600 a month. But you tell that to someone who's paying $500 a month. And if they live in San Francisco and are a family of 4, it's $1,700 a month. Now, you know that in San Francisco, healthcare costs about 30% more than it does in LA because the quality is much better in San Francisco. That's not the case, you know that. So, but the other piece, look at the subsidized Californians. They're paying about $100 a month. Now, I want to remind all of you that you talked about the federal budget, and John did a great job reviewing this, but the unsubsidized individual market are the last bastion of Americans not getting federal help with their health care expenses. For those of you that have employer-based coverage, the federal tax benefit to your employer covers about 1/3 of your health care costs. So the unsubsidized individual market, about 7 million Americans dropping quickly, are not rich. Their median income isn't the $54,000 you heard from John earlier, which is the average median income of all Americans, about $70,000. They can't afford this. So that's a huge issue we all need to look at. Next, I want to talk about benefit design very briefly, and I think that some of the setup you've heard about prescription drugs and otherwise is a really big deal. So I know this is very small print. The main thing I want to convey is everything shaded in blue is not subject to a deductible, okay? At Covered California, we have standardized patient-centered benefit designs that mean for virtually all coverage above the silver tier, which is about 80% of our people's coverage, no outpatient care is subject to a deductible. And I'd ask you to always ask this question. When you hear about high deductible, don't stop there. Ask, what's the deductible apply to? Okay, it's a really, really big deal. And so when you talk about all these great ideas about patient-centered medical homes, 30% of Americans with employer-based coverage have a $2,000 deductible between them and their primary care doctor. You cannot have a functioning patient-centered medical home if you have a consumer saying, why would I go to the doctor if I've got to foot the full bill? So we've actually thought about this a lot. We've also thought a lot about some of the issues that you heard earlier about prescription drugs. Now, I've actually looked at the data and covered California. The #1 drug spend is Harvoni, a Sovaldi knockoff, tens of millions of dollars. It costs, I think, $70,000 for a treatment, cures Hep C, it's great. But if you tell a consumer that's relatively low income that you've got to meet your deductible before you get that drug, many won't do it. So we actually don't just cap the copays, but say you will never need to pay more than $250 a month. We spread it out. We make the drug available. That's a great thing to do. Next, what's working in California? Competition. We got 11 health plans. They fight tooth and nail for enrollment because it's working for them. Jumping over that, I want to talk about what we're doing to address affordability. So we have contracts with our 11 health plans that address things like, starting in 2017, and many of you are aware that California's got a very coordinated care environment with organized medical groups. We still have a lot of things called PPOs, preferred provider organizations, where you sign up and you're told, go find a doctor, okay? Well, starting in 2017, every one of our 1.4 million enrollees was given a primary care clinician within 60 days of enrolling, even in every one of those PPOs. Now, to our knowledge, this is the first time this has happened in the U.S. Large employers don't do this. They should. Getting access to coordinated care early is a key to having good care over the long term. We also push payment change. A number of the ranges that we can do, we do it in concert with CalPERS, with DHCS. Let me take you very briefly to what's coming down the track nationally in the individual market. It is ugly. So Cover California does a lot of work on the policy front, and we worked with our chief actuary and others to say, what's going to happen over the next 3 years absent federal policies to address affordability in the individual market? Over the next 3 years, depending on the state, premiums are likely to rise between 30 and 95%. 95%. Now, this depends on the state, and I'll just show you a picture of the states. They sort of see this. Some states that are redder are going likely to have premium increases of 95%. Now, I'll tell you, and I'm going to go back to why in just 1 second. Premiums go up 95%, you will lose half of the unsubsidized market. Who will you lose? Healthy people. The unsubsidized markets in much of America will become high-risk pools. Okay? That's what's going to be happening. And it's going to be happening for 3 big reasons. Number one, the removal of the penalty. We will have, in California, some hundreds of thousands fewer people with insurance because of the penalty going away. Now, it's a bad gamble, but people will take that gamble. Insurance isn't a natural thing to buy. Second reason you're going to see premiums go up, not doing marketing. Now, again, this is not in California. California's going to be on the positive side on all of these things. But if you don't sell insurance, healthy people don't sign up. If you've got cancer, you got diabetes, you will buy insurance. But if you think, maybe I won't get sick, if you think, I hope I'm not going to be that 1 out of 6 persons each year who ends up spending $10,000, and you want to roll the dice, stay away. Premiums will go up because of that. So marketing matters. That's a huge effect. Third, one of the solutions to affordability being talked about in Washington is what I call going back to the future. The discussion of short-term duration health plans and association health plans is basically saying the Affordable Care Act said, let's have insurance be about getting everyone in and plans competing on delivering better quality and value, not competing on avoiding sick people. That was the name of the game before the ACA. Short-term duration plans are going back to that. It's saying they are cheaper plans, but they're cheaper plans because, yeah, they cover prescription drugs, but up to $3,000. You need Harvoni, you are SOL. That's a statistical term. So, yes, a short-term plan may cover hospital stays, but $1,000 a day. It's going back to the old. And also, yeah, anyone is eligible for short-term plans, but we can charge some people 5 times as much as other people. This is not a solution to real affordability. It's a solution to have cheaper products that the cost will be borne by sick people that are confused about what they're buying. What does that mean for everyone? Some people will buy them, healthier people. Premiums are going to go up for everyone else. So those factors will mean that in the absence of policy changes, the map's going to look like this with a third of the nation having individual markets that have totally tanked and large increases in the uninsured. I know I'm almost at time, and I'll leave you with, there are federal and state policy actions. I was quite disappointed that John did not succeed in making stabilization happen in the swamp of Washington. I think the BPC is doing great work, but there is an amazing amount of rancor and distrust if you spend time on the Hill. The stabilization package that almost was talked about had every one of the first 4 elements on this set of solutions. Reinsurance, directly funding cost sharing, reduction subsidies, and spending money on marketing. It makes total sense, and it didn't happen. And it not happening means premiums are going to skyrocket in 2019 and beyond. There's also state-based options that I think you're going to hear more about from some of the speakers a little bit later, such as having state-based penalties, state regulation of short-term plans, and auto-enrollment. But it is a mess right now. And again, I'm happy we live in California, but if you look around the nation, you do not have the stability we have in California. You have markets that are at great peril. So thank you very much. Next up.
Peter, I think the title of this movie is called Death Spiral. And I think thanks to your leadership, it's maybe a lot less likely in California than the rest of the country. But I think your prediction is death spiral is sooner rather than later. What can we do? I mean, it's obvious that the Congress had an opportunity to act and failed to act. And the issue that tripped it up was abortion, right? How do we get past that?
Well, 2 things. First, I don't call it a death spiral because oddly, given the market dynamics, if you have the subsidies in place, and even at all the repeal and replace, there's subsidies in the individual market, you will have a barely functioning subsidized market supporting a high-risk pool. So there's going to be something there. So death spiral is no individual market. There will be an individual market, but it'll be a very dysfunctional one in many states. And in other states, it'll be functioning. I think it's a little easy to say it was just the abortion issue. It was about the abortion issue, but it was also other elements of the stabilization package weren't as strong as they needed to be. So there wasn't a belief in this is really going to stabilize the market. And so I think that there absolutely needs to be building on the beginnings of bipartisan effort to reach across the aisle. I mean, I think that, and I've talked to leaders on both sides. The issues around abortion are tough issues. But look, we have in California 0 federal funds going in any way, shape, or form to fund abortions in the individual market in a state that has abortion as a right. There are ways to work around restrictions, but it requires both sides to say, we're going to give a little bit. Neither side was ready to give enough on abortion. I sadly think the thing that will tip the scales is, might there be a stabilization deal still this year? These states are going to start seeing premiums announced in May and June. Premiums will become very public in September. Elections are in November. This is not a good time, whether you're a Democrat or Republican, to be running with a 30% rate increase. If there is not stabilization this year, which I think is pretty unlikely, 19 comes pretty soon. And we'll see the effects of the removal of the penalty, and I continue to be somewhat Pollyannish to look for bipartisan solutions.
Okay, thank you, Peter. Amy.